The session will involve 3 short presentations from our speakers and then about 20 minutes of Q&A, chaired by me. I'm Dr. Emily Crick and I work with IDHDP. IDHDP is a membership organisation of over 1,500 medical doctors from all over the world. We're calling for better drug policies that improve the health and well-being of people who use drugs. If you're a doctor and you're not a member of IDHDP, please join up. Adam my colleague should post the how to join us into the chat. I'm really excited to introduce 3 really great speakers who are going to talk to us about how COVID has affected people who use drugs, as well as drug treatment and policy development. Our panelists are Wilson Box, Executive Director of the Zimbabwe Civil Liberties and Drug Network, who will speak about changing patterns of drug use in Zimbabwe during COVID. And then we've got Dr. Atul Ambekar, Professor at the National Drug Dependence Treatment Centre and the Department of Psychiatry in India, who will speak about treatment for people who use drugs in India during COVID. And finally, we have Kassandra Fredrique, who's Executive Director of the Drug Policy Alliance in the US, who will speak about how COVID has exacerbated the marginalisation of people who use drugs in the US. So, our first speaker is Wilson Box. Wilson is the founding member of the South African Drug Policy Network and has been a board member of the Vienna NGO Committee on Drugs. Currently, he is Project Executive Director at Zimbabwe Civil Liberties and Drug Network. Well, welcome, Box.
Thank you so much, Dr. Crick. I'll be talking about the changing trends of drug use in Zimbabwe during the COVID-19. To aid to my presentation, I'm going to be sharing with you a PowerPoint presentation on what I'll be talking about this afternoon. Right, so I'll be talking about the changing patterns of drug use in Zimbabwe during COVID-19. And it's so sad to realize that when we went into a national lockdown in March of 2020, September of 2020, there was no space for most people to move around because of lockdown. It was a strict lockdown, and most people in Zimbabwe could not have access to basic services simply because of this lockdown. You could have a special pass or ID, especially if you wanted to go into the central district in town. So the 6 months between March to September 2020, it was a time when most people who use drugs did not have access, especially to treatment services, because in Zimbabwe, people who use drugs, they are marginalized and they are also stigmatized and to some extent discriminated. So it was very difficult for our community to actually have basic services, especially as regards to treatment. So you'll find out that during this time, most of the people who use drugs, they are not employed. Some of them, they are entrepreneurs, but with the lockdown, it meant there was little movement, if any, and this had a very negative effect on the day-to-day lives of people who use drugs. So you'll find out that during this time again, there was an increase in the use of new psychoactive substances. The traditional drug like marijuana is commonly used in Zimbabwe. But with this lockdown now, there was a lot of new psychoactive substances, especially the rise of crystal meth. Up to this day, crystal meth is actually wreaking havoc, especially on the youth population. Some have been affected to such an extent that they are now having mental challenges. And we've also seen a rise in the sexual gender-based violence. And we've also seen a rise in crime. So all this was happening during this period in time, irrespective of the fact that there was a national lockdown. Most of our community members had to find a way of making a living, and the increase in drug use was actually and is still a cause for concern. And more so with the marginalization still affecting our community, you will find out that most drug users, there is no tangible program for people who use drugs in Zimbabwe. We are a community whereby we are third-class citizens, if I might say, simply because of stigma that goes around people who use drugs. So as an organization, we had to find, partners. Hello, Dr. Emily. Hello, doctor. Hello, Dr. Emily.
3 more minutes.
Oh, thank you so much. So you find out that as an organization, we had to really find partners to assist our communities. We managed to look for food hampers to assist them. And we also looked for treatment services from private doctors in Zimbabwe. But the trend in drug use was so much high to such an extent that it's a cause for concern. And we are also working with different stakeholders to ensure that the rights of people who use drugs are respected, and also treatment services are afforded to our community during this COVID period. And we are happy to say that as an organization and with the aid of frontline aids, we've also managed to come up with the Zimbabwe Drug Master Plan to ensure that at least services are provided for people who use drugs. So it was a time where a lot of new psychoactive substances actually came on the market. And we hope a plan will be in place to ensure that most of our community members are well served, and their health is also respected. So that is what we've been doing as Zimbabwe Civil Liberties and Drug Network, to ensure that at least the rights of people who use drugs, they are respected, and also services are afforded to our community. So with this, I think, Doctor, you can actually take it over, and we hope to have a good interaction session. Thank you, Dr. Emily.
Thank you very much, Wilson. That was really interesting. So our next speaker is Dr. Atul Ambekar. He is an addiction psychiatrist currently working as a professor at the All India Institute of Medical Sciences in New Delhi. He has been involved in establishing treatment systems for people who use drugs and developing the capacities of healthcare providers in India. He played a role in shaping addiction treatment services in India in the context of the COVID-19 pandemic. Over to you.
Thank you, Emily. Namaste, everyone, and good morning, good afternoon, or good evening, depending on the part of the globe where you are. I am going to talk today about what India has seen and what India has gone through in the times of COVID pandemic. What were the challenges and how we were able to address some of those challenges, while some others continue to haunt us and perhaps will continue to haunt us in the coming months and years. So essentially, this is a very brief presentation of about 8 9 minutes, and then subsequently I'll be happy to chat about it. So as we can see here, our COVID situation goes from bad to worse. This is the so-called second wave that India is currently going through, and this, by all accounts, appears to be worse than the first wave. However, as far as the epidemic of drug use goes, or all addictive substances goes, that has been slowly progressing over last few decades in India. So just about 2 years back, we completed the first ever large-scale national survey on drugs. And as you can see the numbers mentioned here at the bottom, there are literally millions of people suffering from alcohol and drug use disorders in India. And even in the pre-COVID times, we have had challenges regarding a very large treatment gap, meaning just a minuscule proportion of people who are needing treatment and care services are actually able to access them. We do have agonist maintenance or medication assisted treatment in the form of buprenorphine and methadone. Largely buprenorphine, there is some methadone centers, but in the pre-COVID era, many of these were largely available to people as directly observed treatment services. So when this pandemic started, the major challenge for people who use drugs was both the pandemic as well as the measures to control the pandemic, that is the lockdown. So which meant double whammy for people, because there was serious restrictions on availability of alcohol and other drugs, as well as serious challenges in accessing treatment and support services, irrespective of where you are an old established service user in the status of a registered patient, or you are a new user who want to now use treatment because drugs are not available. But then even treatment was difficult to access during these times. Now I understand as a side event of CND, we are more interested in discussing controlled narcotics and psychotropics. But as far as people who use drugs and substances go, alcohol remains a very, very challenging problem for many parts of the world. So for us, the treatment sector, number one challenge was this sudden non-availability of alcohol, which led to a spurt in alcohol withdrawal cases. And these have been documented by anecdote, by news media, as well as by systematic research in the form of academic publications and so on. So that was one of the first major challenges which we faced as soon as the lockdown was announced. So responding to this challenge, we, our colleagues basically, we immediately sprang to action. We started helping the government and the civil society in the form of various materials. So there were publicity material, there were educational videos, there were advisories for service providers as well as for the policy makers on how to deal with alcohol withdrawals and its effects. Besides this, the major challenge, in fact, for people who use drugs was this availability of agonist treatment, which is a long-term maintenance treatment in the form of buprenorphine or methadone for people suffering from opioid use disorders. Methadone in the pre-COVID times was available in very limited manner, only as daily observed. But fortunately, India is one of those countries which has had a very long experience with buprenorphine. I mean, we have been using buprenorphine for more than 2 decades, while methadone is just about a decade old in India. So, as part of National AIDS Control Program, even buprenorphine was available at a wide scale, but only largely as a daily observed treatment. Elsewhere, it was available as take home, but for limited durations. And this particular issue of the policies of regulating opioid substitution treatment has been a concern in the addiction treatment community for a very long time in India. So this was a situation even in the pre-COVID times. So with the COVID and the lockdown, this situation was really posed a very, very serious challenge. So again, we immediately started working with our colleagues as well as with the policy makers, and just brought about very quickly some sweeping kind of reforms, basically based upon the general principles of continuing services, ensuring the safety of patients and staff, which means minimizing their exposure, minimizing the need to visit the treatment facilities every day or frequently. And hence, we adopted and implemented policies of more liberal dispensing of both buprenorphine as well as methadone. In fact, since the onset of since the advent of this pandemic, methadone is this was the first occasion when, on a such large scale, we started delivering methadone as take home to our clients. Buprenorphine also, the duration of for which people could carry it with them, that was substantially increased, and we actually saw the positive effects of this in coming weeks and months. This particular issue of take home methadone which we started was covered in the international media, and some many other colleagues came in support of this. Just some of the photographs of the way in which even at the peak lockdown our treatment services continued, be it with the clinic based services. There are also two locations where we currently our center provides mobile methadone maintenance services in the city of Delhi, and the take home methadone was also made available at all methadone facilities across the country. So this was another challenge, and the way we dealt with it. Then capacity building for health professionals. Suddenly there was a spurt in demand for services, and we were not able to provide training to people, the doctors and other health professionals, through the conventional means. So hence we started again, like all of us are currently facing a pandemic of Zoom webinars as well, and we are currently having one of these. So the similar means were adopted, and we adopted the exploited actually all possible ways in which information technology can be used for the purpose of spreading the messages among the fellow professionals. So we actually developed very urgently, very quickly, online training modules, and these are not in the form of a someone talking to you, right? These are more in the form of interactive powerpoints where you can play with the powerpoint slides, click on some buttons and gain knowledge, and only then you proceed forward and so on. So those systems have been developed and now have been put in place, and we are receiving some encouraging response so far. It was also important to document whatever is happening at this moment. So we early in the epidemic itself, we instituted a system of online monitoring for the service providers who directly work with us. And though it has not undergone systematic publication, and that's a work in progress, but the early impression is that alcohol and illicit drugs, they continued to be available in the lockdown, though at a slightly higher prices. There has been a slight reduction in the footfall at treatment facilities owing to a variety of factors, including lockdown. But the good part is that we hardly got any reports, significant reports of diversion of take home buprenorphine or methadone, which we provided to people. So, contrary to fears, contrary to the preconceived notions, heavens have not fallen down when we have given buprenorphine or methadone in the hands of people so that they can take at their homes and keep themselves safe. So that's something very encouraging, and that's something I think a lesson learned for everyone across the world. So even in the post-pandemic world, perhaps there is something to learn from this experience. Another trend, which is I think everywhere in the world, which is coming up, and in India also very certainly it came up in a big way, is the telehealth issues. So telemedicine, telepsychiatry, all those guidelines were developed, were put in place by the government and other stakeholders. Unfortunately, these guidelines do not allow prescription of narcotics and psychotropics such as methadone or buprenorphine through the telehealth mechanisms. Now, I really don't understand why can't this be done. I mean, I can still be, I can still accept that for the first visit, perhaps it's prudent to have the patient personally be seen by a doctor and the prescription be personally delivered. But for a stable patient, for a continued treatment and just refilling of prescription, why shouldn't it be allowed through the information technology means? Is something beyond me. So this kind of advocacy for this is perhaps a work in progress, and hence I think international organizations like UNODC, WHO, through their normative functions, perhaps for assisting member states, can perhaps develop such advocacy and technical tools, as well as the professional societies like IDHDP can do more advocacy in this regard. So to conclude, I don't think the worst is behind us as far as this pandemic is concerned. We haven't seen the tail of it. We also don't know what's going to be the drug use situation in the post-pandemic world. Those contours of that world remains something to be seen. People who use drugs will continue to be vulnerable in many different ways, both for COVID as well as the effect of various other policies which have been put in place. It's high time to start reimagining the policy and practice of addiction support services. Also, an opportunity for doing good operational research and implementation science research. Overall, a more liberal approach towards practice of addiction medicine is required. And for this, involvement of key stakeholders, mainly the civil society and the beneficiary community, people who use drugs and their networks. I think that would be crucial. Thank you very much. I'll be happy to be involved in further discussion on this.
Thank you very much. Thank you very much, Atul. That was really interesting. And now our next and final speaker is Kassandra Fredrique. Kassandra is Executive Director of Drug Policy Alliance, a US nonprofit organization that works to end the war on drugs and build alternatives grounded in science, compassion, health, and human rights. During her time at DPA, Kassandra has built and led campaigns around policing, the overdose crisis, and cannabis legalization, each with a consistent racial justice focus. Thank you, Kassandra.
Thank you for having me. I'm really excited to be here. So I don't have slides as the other two speakers. So I've organized my talk to really talk about what we have seen in COVID in terms of drug user health, as well as how we've seen our systems react to COVID and trying to navigate folks. So based on what we've seen of COVID-19 in the US, what we have documented and what we predicted was that our overdose crisis, which for the last couple of years had started to level off, would increase. That the forcing of people inside, the isolation, the restrictions, and the really shutting down of services would only force people inside and create the circumstances where people would really struggle with navigating their use, and for some, how their use might become more chaotic. And that is exactly what we've seen, right? So we have seen overdoses increase pretty dramatically. And we've also seen the kinds of overdose also diversify. So oftentimes, as we have been saying, is that what is fueling the overdose crisis currently has been a drug poisoning crisis. So adulterated supply. So for us, what the overdose crisis has shown us is that the US is in dire need of safe supply because our supply has been poisoned and is being cut with adulterants. And so in the US, the most popular adulterant that's cutting our opioid supply is another more powerful opioid of fentanyl. And folks either know or don't know and are not being given the information about how to navigate these things through. And so one of the things that folks are recognizing in the US is that as we navigate COVID-19, the overdose crisis is skyrocketing under it. And so we have an epidemic within a pandemic. And this is a lot of the things that we have been talking about for a very long time about what a crisis like the pandemic, though no one predicted it, would only exacerbate these things. COVID-19 exacerbated all the structural inequities in our healthcare system and in our housing systems in the US. So when COVID-19 hit, a lot of our harm reduction organizations were kept out of the planning for healthcare provision. So our healthcare providers, our harm reduction organizations were without PPE. They were without additional funding in order to find people. And so our harm reduction agencies across the country took on additional responsibilities and risk to find people who were using drugs, who were unhoused, to try to get them to continue to get them the safe supplies that they needed around sterile equipment, but also giving our folks in the street masks. And then also trying to give people the information and the resources that they need to make their use safer. And so what it also showed and reinforced was the supplemental healthcare, the shadow healthcare system that we have for people who use drugs. And what started to be clear was that health departments across the country were like, oh, we actually need to deal with the healthcare infrastructure of harm reduction organizations. So in New York, for example, when the vaccine process started being rolled out, harm reduction agencies in New York City, for example, were considered healthcare workers when they weren't in the beginning of the crisis, when we were talking about getting access to PPE and providing support. So we were navigating, in the US, we're navigating this situation where people who use drugs were forgotten, as marginalized communities always tend to be, but also that the infrastructure that is set up, if we didn't have our harm reduction infrastructure, we would have had way more people who use drugs die. Our harm reduction agencies are the unsung healthcare workers that really did an immense amount of work to keep our communities alive and navigate an extreme health crisis. And I think because our movement is inherently more creative because we have less, our harm reduction agencies were not just navigating the death of people in our communities from COVID-19, but the death of our people from problematic drug use, which could have been prevented if our structural inequities were not in place. Or if people thought of us in the beginning of the crisis, they thought about marginalized people in the beginning. These are the people that are unhoused. These are the people that are incarcerated and coming out. Because one of the things that was also a push in the US was the decarceration of local jails to try to get people who are in there with certain charges to come out. And a lot of people, as we know in the US, there's substances inside, and when you come out, the overdose goes up within that 4-week period. And trying to get those people connected to services. So we had people in the street, we had people coming out, and the infrastructure was inadequate to deal with the very immense need that we had. But it was not all. The COVID has also, like Dr. Atul laid out, there were things that we were able to navigate in the US that really showed how much the government impedes access to healthcare for people who use drugs, where when push came to shove, we realized that it wasn't necessary. So buprenorphine and telemedicine, all these red tapes were reduced. We saw district attorneys around the country decide to decline to prosecute drug charges. So one of our more popular ones, Marilyn Mosby in Baltimore, decided that she would no longer prosecute drug charges or sex crimes. And last week she decided, I will no longer do that after. So after COVID-19 is done, I will continue to not prosecute these charges. So what we're seeing is that there are some folks that change things, our criminal legal system, some prosecutors who change things to navigate COVID-19 are seeing that those changes, which are long-standing changes that the advocacy community has been fighting for, did not increase crime, right? The sky did not fall. So let's actually keep these criminal justice progresses in place and see how we can actually do the thing that we needed to do, which is create a stronger infrastructure for healthcare for these communities. But this has also elevated a fissure between harm reduction communities, criminal justice communities, and treatment communities whose referrals are based on the criminal justice system, who are struggling in this moment because they don't have coerced, involuntary participants. And so it's pushing a conversation about why treatment needs to be voluntary, why treatment needs to be improved, why treatment needs to be harm reduction based, because COVID has exposed the profit modality in the treatment system within the United States in a different way than people had anticipated. And so I think one of the things that we have consistently seen in the US is it has reinforced everything that the drug policy reform movement has said would be a problem around our structural inequities. But we've also seen some movement in reforms as COVID has pushed. We've added 8 more states for cannabis legalization. We have seen the decriminalization of drugs in Oregon. We've seen prosecutors remove drugs as something that they would prosecute against. And you've seen an immense amount of pushback against law enforcement engaging with drugs. And so in the US, what we've seen is a posture towards liberalization against the drug war. And so you'll also see that in our United States President Joe Biden's stance around drugs and addiction and his first year priorities that have been moved in towards more of a liberalized way. This is not to say that things are all right in the US. We still are in a devastating overdose crisis, devastating homelessness, devastating food insecurity, a law enforcement system that is unaccountable, disregard for Black life. Another person was killed yesterday. And I think that what COVID has pushed is given drug policy reformers more urgency as well as more data to push back against the infrastructure and to push the government to actually take on some of the things that we adjusted for a global emergency. And so while more people are dying, we are trying to navigate how to stem that, how to diversify our conversations and policies and innovations around that to stop the killings and I call them killings because every overdose death is preventable, but also the policies that we have put in place and the experimentation that decision makers put in place because they couldn't fight a drug war and fight COVID-19 at the same valor, how we keep those things in place as we move forward. Thank you.
Thank you very much to all our speakers. That was really fascinating. If you can turn your cameras on and we'll try and have a little bit of Q&A now. One thing that I would be interested in asking Wilson is because both Kassandra and Atul have talked about how there has been some innovation in drug treatment, particularly in India and the US. And I just wondered, Wilson, have there been any innovations in Zimbabwe that could be seen as positive? You're on mute. Yeah,
Right, Doctor. Oh, thank you so much. Right, in Zimbabwe, we can see that there has been some innovation in terms of treatment. People who use drugs, we're actually advocating for that. But what we have done, much to our satisfaction and also our community, was the production of the Zimbabwe Drug Master Plan, which we actually put in place together with 14 other interministerial committees in Zimbabwe. So the master plan is actually in its earlier stages of implementation. And we hope that with the current crisis of drug use in Zimbabwe, we are hopeful that it is going to be adopted holistically so that people who use drugs can have access to treatment.
Thank you very much. And also, just sticking with you for a moment, because Atul mentioned a lot about alcohol, and I wondered whether you've seen similar issues in Zimbabwe with like a big problem with people who are dependent on alcohol as well.
Yes, we do have alcoholism challenges in Zimbabwe because alcohol is a tradition in Zimbabwe. But during the COVID-19 lockdown, we've had a lot of overdoses because some of these alcohol patterns, traditionally made, and some of them can be very potent and also, harm the users. So the issue of alcohol has been very high, especially on our younger generations, that is youth.
Thank you very much. So we have a few questions from our attendees. So one for Kassandra. Have you heard of increased adulteration in drug supplies during this period?
Yeah, so one of the things that we heard pretty early, and one of the things we watched was what was going to happen to the drug supply in the U.S. And I think one of the things that we have seen is fentanyl spread across the country as a way to extend the heroin supply. And so it's why in the U.S. the calls for safe supply are increasing because I think we've always been moving there, but I think the urgency and the timeliness around it has increased because folks have felt that the supply has gotten more volatile.
Thank you. And Atul, have there been any studies into kind of adulteration in drugs in India as well?
Not really systematic studies, but we did get some anecdotal information from patients who are coming to us for treatment. And as per they say, there has been some difference in the quality, which means what they get is now much more slightly diluted. But the kind of disruption one would have expected, with such serious lockdown, one would have expected a complete disruption of supply of drugs at the wholesale as well as at the street retail level. That has not happened. So which is surprising and which tells us a lot about the way drug markets work. So but yes, from what appears, that there hasn't really been too much of a change, too much of a disruption in the drug availability in India.
Thank you very much. So I think it would be really interesting to reflect on how the COVID pandemic, some of you have talked about innovations that have been going on in your countries. So how can we learn lessons from what has happened in the COVID pandemic? And how can we as a global community, but also communities within your countries, think about how to improve marginalisation of people who use drugs? It would be great if any of you could give us some insights. Wilson?
Thanks so much, Doctor. I think what we can actually do first and foremost is to really support people who use drugs so that the issue of stigma, marginalization, and also, looking at drug users as third-class citizens should actually come to the end. Because people who use drugs, first and foremost, they are human beings. They've got their rights, and they also need to be respected. So once our people could really get to appreciate that, I think we can actually go a long way.
Thank you. Kassandra or Atul, have you got any reflections?
I think it would be very important for us working in this area to continue to advocate for drug using populations as the vulnerable group for both the pandemic, the infection itself, as well as the measures for the pandemic. We have all seen how the health systems can get disrupted during such pandemics. We have all seen the necessity of arranging the health services in a hierarchy. So the priority health services must continue. The non-priority can take a back seat, and that's the formula everyone around the world has been working on. In that list of priorities, people do not realize that addiction treatment and support services are also very, very important, because anyone remaining unsafe is all of us being unsafe, so it's important to ensure safety for everyone, and hence it's important to continue to fight for, continue to raise voices for people who use drugs as the community, which need to continue to remain and in the priority list for all healthcare interventions, including for vaccinations. I would argue strongly that if at all there is any list of hierarchies being drawn, then people affected by drug use disorders must be seen as the priority group for vaccination. So that's something I think an agenda for all of us working in this area for the coming future.
Thank you.
I think what both Wilson and Dr. Atul said is right. And I would also, what I would say is that what COVID-19 really pushed for me is that there are things that made people who use drugs vulnerable that had nothing to do with their drug use. So the fact that they didn't have housing, the fact that they didn't have food, the fact that they didn't have certain things to keep them safe. So when COVID-19 came out and everyone was like, no congregate housing, wash your hands, get ready for lockdown, people who are in chaotic use, who don't have access to homes, who don't have access to steady food supply, they were the most vulnerable. And they were most vulnerable not even because of their drug use, right? That people who use drugs, their drug use is one part of their situation. And we know it exacerbates a lot of things. And we know that that's the issue area that we focus on. But they are whole people. Their drug use does not make the fullness of them. And in a crisis like COVID-19, which really emphasized the need for housing for all and like food for all and access to running water, it reinforced to me that as a movement, we need to push our colleagues in other movements to consider people who use drugs, to center people who use drugs in your housing campaigns, to center people who use drugs in your portable water campaigns, to center people who use drugs in your food security campaigns, because drug use alone is not the only thing that made our folks vulnerable to COVID-19, right? In fact, it was their connection to drugs that got them access to PPE in the US. It was their connection to drugs that got them access to being considered a high risk and a vaccination priority in the US. It was their connection to drugs that connected them to COVID-19 supports and being able to get them into hotels so that they could get methadone. COVID-19, their connection to drugs got them connected to these things because we had a supplementary healthcare system for them, where we had harm reduction organizations and organizers who were advocating for them, right? And so I think for me, what COVID has shown is like, we're doing our movement, our drug policy movement is doing as much as we can, and we're doing way more. But other people and other movements need to take into consideration that our vulnerable population are their vulnerable populations as well.
Yeah, thank you. That's really interesting. And one of the questions that came up is, are there moves in your country, any of you, to house homeless populations? So I know in the UK during the first lockdown, there was some move to house homeless populations, although that then tailed off. And I wonder whether there have been moves in other countries to do something, in India or in Zimbabwe. But perhaps there isn't. But I think that's a really valid point, Kassandra, about how drug use can make people more marginalized, but the marginalization can actually be the problem far more than the drug use in many instances. And that's really interesting what you say, that actually drug use was the thing that helped some people get into some form of treatment.
Well, are being connected to our movement, right? So harm reduction organizations really serve as the connector for people who use drugs to be connected into the broader efforts around COVID-19 because you are a participant at Vocal New York, you know, Vocal was able to get their members vaccinated in the early stages of the pandemic, right? We were having people be in empty hotel rooms, getting in, right, as part of the homeless population, and then fighting to make sure that we could get methadone delivery to those hotels in New York City. That didn't happen throughout the country. I'm just giving an example of how being connected, because our movement is fighting and strong and respected in some ways, we were able to advocate to be like, no, this marginalized group, this specific marginalized group of people who chaotically use drugs should be a part of the big plan. And I think that that is more reason for our movement to be more intersectional and to see the people that we serve as more than people who use drugs, but as people that are living at the margins of society that are also navigating other structural issues. And so the way that we talk about folks has to be reflective of that.
Absolutely. Thank you very much. So we're coming to the end. I wonder whether Atul and Wilson have any final thoughts about that, particularly reflecting in a way on the people who can provide support in your country. Maybe, you know, maybe not the healthcare providers. Are there other organizations that can provide this kind of support, similar to how they have it in the US, where there is a development in harm reduction?
So thank you so much, Doctor. Yes, in our country, in Zimbabwe, since we started advocating for the rights of people who use drugs to be observed and also access to treatment, we have seen a growing interest of participants from all sections of Zimbabweans being worried about the current, challenges in drug use in the country, to the extent that the issues to do with challenges in drug use are now being discussed at the national level, even to the Parliament of Zimbabwe. These issues are now being discussed. So we are so much motivated, and we hope the discussions will actually go to another level where treatment services will be afforded to people who use drugs, and also opportunities are being availed to people who use drugs, because above all, people who use drugs, they are human.
Thank you. Atul?
Thank you. Yes, I think this pandemic has served as an opportunity to expose a lot of fault lines in the society in general. The inequality in the society, which may account at various levels, which may affect people on various accounts, has really been come out on the fore. So one of those many factors, as Kassandra also rightly said, is maybe drug use. So drug use can be just one of the factors because of which certain peoples are more vulnerable than the others, and hence this pandemic has shown the importance of looking at the social as well as healthcare issues for the entire society as such, and looking at the particular vulnerability of the populations. So that's something an important takeaway from this particular pandemic. Secondly, the pandemic is also an opportunity. Pandemic and its response is also an opportunity to once again reflect upon what we see as a priority for our society going forward, whether health, support, welfare, which of these things are luxury and which of these things are necessity. And this actually, the discourse on it became sharpened in India in the context of lockdown and alcohol non-availability. Right. So for first few weeks when alcohol was not available, I was just looking at the chat and there was a comment about this in the chat window as well. So when alcohol was not available and people were suffering, people who suffering from dependence were suffering from serious withdrawals, then there was this discussion: should alcohol be seen as a basic essential necessity, which is important for survival, or is it a luxury item which perhaps society can live without? So I think pandemic is giving us this opportunity to examine all of these things in bare details, and perhaps a renewed vigor with which we can advocate for people that we work directly with. So I really like Kassandra's suggestions that drug use advocacy should now become a mainstream part of advocacy of all other social issues which are taking place. Somehow, even within advocacy, there is an hierarchy. You are a cleaner guy if you are advocating for something else, but you are not liked if you are working for people who use drugs. So those are the bridges which we need to cross. Those are the gaps which we need to bridge. Thank you.
Thank you very much. Kassandra, do you have any final words?
No, I think Dr. Atul's point around people who use drugs being prioritized in vaccination is crucial. And I think that that's one of the things that we all need to be advocating for, because as we know, if it was up to our decision makers, our community wouldn't be here. And so we have to make sure that we don't give them the out, and that we advocate that in a post-COVID-19 world, our communities are still here, and that we advocate, as the world is shifting, that we advocate that we keep the innovations in place, and we get more urgent, because COVID-19 has showed why people who use drugs and their marginalization is a health risk for everyone.
Thank you very much. Well, we very slightly run over, but I want to say thank you so much to our panelists. It's been a really interesting discussion. Thank you very much. Bye.
Thank you, and bye-bye, everyone. It was a pleasure.
Thank you. Bye-bye.
Bye.